Thank you for having me. And as Robin mentioned, um, part of what I do is work with the Epilepsy Study Consortium, which leads to my slides. So my disclosure slides. And the Epilepsy Study Consortium is a nonprofit group that helps companies developing new treatments for epilepsy in designing and executing trials for new therapies. And as part of that work, I do consulting for the consortium on behalf of several pharmaceutical and companies. These are the rest of my disclosures, and I was invited by my colleague and mentor Jackie French to join the consortium, and I have found that work really rewarding. And one of the things that it's really done is help me understand how treatments come to patients. So in this talk, I will start out with talking about the current treatment gaps in our epilepsy therapy. I'm an adult epileptologist, and I primarily, treat what I'll call the common epilepsies, focal and generalized epilepsies, um, uh, and not DEEs. We'll talk about some new developments in treatment of drug-resistant epilepsy and talk a little bit about emerging therapies for focal epilepsy. And then we'll talk a little bit about targeted therapies in development for genetic epilepsies and DEEs, review some new concepts in treatment for the epilepsies. In the interest of time, I'll just glance on the need for novel trial designs, and we'll talk about future directions. So I'll start off with a case presentation. So you're seeing a 28-year-old woman in the clinic who has a history of depression and was seen recently in the ER after a convulsion. The evaluation in the emergency room was unremarkable, but you take a careful history, and for several years, she's been complaining of rare episodes where she hears a buzzing in her ears and feels confused for a few seconds. She attributed this to panic attacks and never sought medical attention. You order an MRI and an EEG. You identify that she has a focal cortical dysplasia in Heschel's gyrus and left centrotemporal spikes. So you've diagnosed her with focal epilepsy, and you set upon choosing a treatment. Our treatment is symptomatic, right? We choose medications to prevent recurrent seizures, to reduce the risk of mortality from seizures, accidents, and drowning, and SUDEP, and the morbidity from seizures as well, both from injury as well as the long-term cognitive and neuropsychiatric consequences of epilepsy. And then, things to improve the quality of life, to allow safe driving, to allow engagement with work and family life. So how do we go about picking these symptomatic treatments? We have a lot of drugs to choose from. You'll see this famous graph is presented at every discussion of gaps in epilepsy therapy, but we definitely have many treatment options for focal epilepsy. We know that these medications haven't really moved the needle in the proportion of patients who are seizure-free. When Kwan and Brody looked at this back in 2000, following the introduction of these second-generation anti-seizure medicines in the 90s, about 2/3 of patients who were seizure-free with pharmacotherapy. When they looked again in these cohorts of epilepsy clinic-treated patients 12 years later, that number was stubbornly the same. So we haven't really made that much progress in making people seizure-free. Uh, and even with the drugs that we have for initial therapy, we need some better choices. So this woman is 28 years old and has comorbid depression. And so you may want to avoid certain medications, things that may influence, can worsen mood, may not be ideal for focal epilepsy, things that, medications that may have significant toxicities for use as first-line therapy. Um, She's also taking oral contraceptives, and so you're worried about drug-drug interactions that may lessen the effect of her birth control pills. And she's also has some concern about the potential for weight gain. So in reality, after selecting, after all these possible drugs that you choose from, you have only two medicines really to choose from. And she's recently partnered and is thinking about having children in the near future. And really, of those two choices, now you're down to one. And most importantly, she's young and doesn't want to take medicines forever. And now you're you're down to none. So we have a lot of opportunities for improvement in our therapeutic armamentarium. I kind of like this complicated schema about how epilepsy, represented on the left here, and all the different ways it impacts quality of life. These things with the green stars are at the end of the day, the things that our patients really want to improve. And these things in red are things that maybe we want to address as upstream drivers of all the things that improve quality of life. So where can we intervene? We can intervene with our medications to improve seizures. Efficacy is probably is an important driver of quality of life in patients with focal epilepsy, but it's not just some efficacy, it's seizure freedom, and being seizure free is perhaps the biggest single driver of quality of life in patients with drug-resistant focal epilepsy. We have this data from epilepsy drug trials, add-on trials, and that the biggest change in people, this is for this study, analysis of the study of levetiracetam, the biggest improvement in quality of life was seen in the very small population of patients who became seizure-free in the randomized control arm of the trial. We see this also in epilepsy surgery as well. We have opportunities to give us better treatment, meaning specifically treatments that are more tolerable. So medication side effects are a significant burden with people with epilepsy, and then adverse events are a large contributor to the negative quality of life. As everybody knows, there are multiple different types of intolerability, both predictable and unpredictable, from direct drug effects, acute and chronic. And there's an interaction between tolerability and efficacy. If you can't tolerate a sufficiently high enough dose of medicine, you may not achieve brain concentrations that are most effective. And so we could see that for some of our medicines, there may be a lack of efficacy in our patient population because their therapeutic ranges are narrow. So this is the data dose response data from lacosamide trials, and you can see that with each increasing dose, there's increasing efficacy. And, it's not clear if you kept on going up, if tolerability wasn't an issue, would you get better and better outcomes? These are 75% responders. Obviously, there's opportunities for improvement in modifying the underlying disease, the epilepsy. So we don't have anti-epileptogenic treatments. We just have anti-seizure treatments. And so that is certainly a place where we need better options, or options at all. We'll talk about that a little bit later. And then comorbidities. So comorbidities are common in focal epilepsies and generalized epilepsies, including mood and cognitive comorbidities. They're worse in drug-resistant patients, and they can be due to the seizures themselves, the effects of medications, the psychosocial effects of having a chronic illness, and perhaps the underlying biological abnormalities leading to the epilepsy itself. So the same circuits that are involved in generating the seizures may also be circuits involved in mood or memory, and may not be functioning as well interictally as you'd like them to. And so certainly medications that target comorbidities and at the least do not exacerbate them are sorely needed. And then finally, we talk about disease modification. No treatments exist. Some other treatment gaps to consider. We don't have a lot of options for our patients with idiopathic generalized epilepsies. Usually, trials of new therapies for IgE are an afterthought. They typically occur after trials for focal epilepsies for appropriate drugs. They are slow and difficult to recruit, and so we don't often have the evidence base we need to determine if new drugs are good for IgEs. One example is the lacosamide study for primary generalized tonic-clonic seizures. Took 12 years after it got the label for primary generalized tonic-clonic seizures for lacosamide took 12 years to approve after it was first approved for focal seizures. Companies have started to be aware of this issue, and often are now doing parallel studies for primary generalized tonic-clonic seizures. And then the last issue that's important to address is teratogenicity. New drugs their teratogenic potential is often unknown and untested. So people of childbearing potential are often unlikely to benefit right away. All right. So what are things in the pipeline for the common epilepsies? One thing before we start is I'm going to posit that we might have entered a new era for treatment of drug-resistant epilepsies. And I think our expectations, at least around efficacy, may have changed, and I think they've changed because of two recent developments. The first is the trials, the approval of cenobamate for focal seizures, and the other is the approval of fenfluramine for seizures related to Dravet syndrome. And so cenobamate, as many of you know, is an alkyl carbamate. It has probably two known mechanisms of action. It inhibits persistent sodium channel currents, as well as is a allosteric modulator of GABA A receptors. And and what was remarkable in the pivotal trials of cenobamate is the frequency of seizure freedom amongst trial participants and its dose dependence. So in the highest dose, 400 milligrams per day, 21% of patients became seizure-free in one of the two pivotal trials during the 12-week maintenance period. And that's compared to 1% with placebo. And it is comparing apples to oranges a little bit, but if you look at seizure-free rates during the double-blind period of other add-on trials for drug-resistant focal epilepsy, this is pretty remarkable. Levetiracetam achieved 7%, topiramate 5%, but the rest of them are very few patients became seizure-free in these trials. Fenfluramine, also thought to be a game changer in the treatment of seizures in Dravet syndrome. Fenfluramine is a drug that acts on the serotonergic system, including multiple agonist activity at multiple serotonergic targets, also modulates sigma receptors, and it had a 55% greater efficacy over placebo for convulsive seizures. 8% of the children achieved convulsive seizure freedom compared to 0% with placebo, and about half of them had a 75% or greater reduction in seizures. So pretty dramatic therapeutic response in a notoriously difficult to treat population. So what I want to posit is that this these two compounds have kind of reset the bar for what we think a effective therapy should be. So I'm going to go over a couple of drugs that are currently in development. These are drugs in active clinical trials. And it's not meant to be comprehensive, but just to get a sense of what directions people are heading in to achieve that high bar of therapeutic success. So the first class of drugs that are in active clinical development are potassium channel modulators. So targeting primarily the Kv7 currents. These are G protein coupled receptors that are expressed in neurons and heart cells, smooth muscle cells, and have been the targets of anti-seizure medicines because they increase neuronal they decrease neuronal hyperexcitability by driving them to a more hyperpolarized state. As you may recall, we did have a potassium channel modulator approved in some places called ezogabine or ertigaine. And it had modest effects in clinical trials for focal epilepsy, but it had a peculiar set of side effects, including blue-gray pigmentation of the skin and the retina related to the chemical properties of the drug, and there was never wide uptake, and it came off the market. There's a couple of new Kv7 targeting anti-seizure medications that are currently in trials. The one that's furthest along is this Xenon 1101. It's a potassium channel opener, has increased potency compared to ezogabine or ertigaine, and And in a phase 2 study, it seemed to have significant efficacy over placebo at 2 out of the 3 dose arms, and now is in phase 3 trials for both focal onset seizures and primary generalized tonic-clonic seizures. There's some signal, and the drug is also being developed for mood disorders. The primary phase 2 trial for depression failed to meet its endpoint, but there may be some signal of efficacy. At least it may not. It's unlikely to worsen mood symptoms in people with epilepsy. There's a second potassium channel drug in development, the Biohaven 7000 compound. It activates Kv7.2 and 7.3 channels, has some GABAergic, has minimal GABAergic activity, so it's perhaps a little sedating. It seems to be well tolerated in early human studies, and so the company was pleased with their early results that they're moving directly into phase 2-3 trials. So I apologize. I just made a mistake. I'm gonna switch slide decks. I just lost my slides.
Thank you for trying to fix it, Daniel. I appreciate it.
Yeah, I just I opened the wrong slide deck. Sorry.
No worries, no worries, no worries. Thanks.
Is everything okay there?
Yeah, sorry about that. Do you see
Yeah.
my screen again?
Yeah,
Now we
thank
can
you.
see it just perfect.
Okay,
Thank you,
sorry
Daniel.
about
No, no worries. Thank you.
that. So there are also new sodium channel modulators. Sodium channel drugs have long history in treatment of focal epilepsy, and there's a new compound that's in active clinical development that called Prax 628. It's an activity-dependent blocker of the 1.6 sodium channel current, same target as part of the mechanism of action of cenobamate. It appears to have high potency. It recently showed efficacy in a proof of concept study where it blocked the photoparoxysmal response in patients with PPR, a proof of concept model for focal drugs. It is now entering phase 2 clinical trials. Some novel mechanisms that of interesting medications that are emerging also in trials. This compound from Rapport Therapeutic, RAP219, is an allosteric modulator of a protein called TARP gamma 8. And it's a receptor-associated protein that is part of the AMPA receptor complex. And what's interesting about these receptor-associated proteins is they have differential expression in different parts of the nervous system. And this particular TARP is only expressed in the hippocampus and to a lesser extent in the cerebral cortex, as you could see in this radiograph from a rat brain. And the concept behind using these mechanisms is you can have drugs that target receptors that we know may be involved in excitability and pathological excitability, like that in epilepsy, but only at the areas where you need them, and perhaps not in the areas if you don't, like the cerebellum or the brainstem, and reduce off-target CNS toxicity. We know this drug reduces AMPA currents. It appears to be well tolerated in phase 2 studies, and there's a very interesting phase 2A proof of concept study that's currently in progress, that's using patients that have an implantable neurostimulator and using the recordings from that stimulator as the primary outcome measure. Another drug that's in clinical development is one that's been that's ancient, so it has an ancient history. So this drug, SPN 817, is a synthetic analog of huperzine, which is a compound found in club moss, which has been used in ancient Chinese medicines. It's a reversible potent selective central cholinergic inhibitor. It may have some anti-inflammatory effects through nicotininergic receptors, and it has a broad anti-seizure activity in a wide range of animal models of epilepsy. Probably not through its muscarinic effects, because it occurs even in the presence of atropine. And there's currently a phase 2A study that's in progress for focal epilepsy. There are also obviously seizure medicines that are being developed for very specific syndromes and etiologies. Syndrome specificity can occur for two reasons. One is commercial. There's incentive for developing treatments for rare syndromes through the Orphan Drug Act and similar acts in Europe that gives commercial advantage for treatments that for small disease populations, like those with specific epilepsy syndromes or genetic conditions. And some of the reasons why medications are developed for specific genetic epilepsies or syndromes is probably more commercial than scientific. So there's no clear scientific reason why a medication like cannabidiol, for instance, would work in Dravet syndrome, but not other forms of epilepsy. And then there are drugs that have scientifically valid reasons for being specific. So one example would be drug like everolimus, which has been approved for the use of treating seizures due to tuberous sclerosis complex, because there's a real mechanistic link. So what are some of the emerging therapies for specific syndromes, or even the DEs as a broad category? One interesting one is bexicaserin, which is like fenfluramine, has action in the serotonergic system. It's a little more specific for the 5-HT2C receptor and doesn't have the sigma receptor activity. The other thing that's interesting about it is that the company looked at in their phase 2 trial across a broad range of developmental epileptic encephalopathies, including Dravet, Lennox-Gastaut, and others. And they found in that study there was a reduction of motor seizures, major motor seizures, by 53% in the treatment arm and 21% in the placebo arm. And currently they're launching phase 3 studies that are actually one targeting Dravet syndrome and one targeting a broad range of DEEs. So not just LGS as trials have done in the past, but it will include patients that don't fall into that sort of narrow syndromic definition. There's some also DE genetic small molecule therapies that are being developed based on disease mechanisms. This medication, latudrogene, is an inhibitor of persistent sodium currents, and it has been recently studied in genetic epilepsies due to gain of function sodium channel mutations, specifically SCN2A and 8A, in a randomized trial of 16 patients in Europe. 5 in the treatment arm became seizure-free across both syndrome type, both these syndromes, and none in the placebo arm. So it's also being further developed. So what about new concepts? New concepts in epilepsy therapy. Probably the most exciting one is those targeting pathological gene expression, because they hold the promise of disease modification, of precision and personalizations, and of these kind of targeted therapies. Probably antisense oligonucleotide therapies are the furthest along in clinical development. And antisense oligonucleotides are synthetic strands of nucleotides that bind mRNA floating in the cell and influence translation of genes and expression of proteins. They're sort of engineered to be small and to not be degraded by the normal mechanisms in the cell. Their problem is it's very difficult to get them into the blood-brain barriers. Right now, they're being delivered intrathecally, but there are companies working on novel delivery systems to allow for intravenous delivery. And there are multiple ways that ASOs can modulate protein expression. They can reduce expression. They could influence degradation. They could change into alternate splicing variants. It's now becoming an established model for treatment for genetic diseases. Nusinersen was approved, the first ASO approved for treatment of neurologic disease, for the treatment of SMA, now 8 years ago. So probably the ASO that's furthest along in development for epilepsy is zorovanersen, or STK-001, for treatment of Dravet syndrome. And about 85% of patients with Dravet have a loss of function heterozygous mutation that leads to a haploinsufficiency of functional protein. And so ASO was developed to increase expression of that good wild type allele, and it by preventing alternate splice preventing the degradation of that transcript. So you can increase the amount of mRNA floating around that codes for the wild type channel and drive up protein expression. That's been shown in animal models and non-human primates. And that leads to fewer seizures, decreased mortality in the mouse model. And then recently, 2 early phase studies were completed, open label sort of dosing and safety studies. But in these studies, the higher dose arm, especially one that higher dose, multiple dose arm, they demonstrated a 75% reduction in convulsive seizure frequency after 6 months from the last dose. So suggesting that there are potentially durable disease modifying effects. And so next next randomized trials are currently in progress. Another exciting approach, cell-based approach to treatment of epilepsy is stem cell transplants, and particularly interneuron progenitor cell transplants. So there's been some work primarily led by the laboratory of Scott Baraban in using interneuron progenitor cells and implanting them into epileptic tissue, where they can integrate and form functional inhibitory circuits to help control seizures. And they've demonstrated probably the most famous proof of efficacy of the concept was Cronut the seal, who developed intractable mesial temporal lobe epilepsy from domoic acid poisoning from eating bad mussels. And he received a stem cell transplant and became seizure-free. There's now also a company that is using human pluripotent stem cells derived from fetal tissue to treat mesial temporal lobe epilepsy. They are in the midst of a phase 2 study right now for unilateral drug-resistant MTLE, and then I think soon to be also including people with bilateral MTLE. I'm not going to touch a lot about neuromodulation. We have several neuromodulatory therapies. VNS obviously has been around for a while. Deep brain stimulation and focal responsive cortical stimulation are also established therapeutic options. This is an interesting publication published last year in JAMA of a less invasive approach to neuromodulation for epilepsy. This is a subscalp over the skull stimulator that delivers weak electrical fields over the cortical convexity to treat well-localized focal epilepsies. And they completed an open label trial that showed a portion of the treated population had long-term benefit, and they are also they are also starting randomized controlled trials soon. So in summary, we talked about the treatment gap, that many of our patients with epilepsy still have poor seizure control, at risk for side effects from epilepsy, experience the comorbidities of epilepsy, the mortality risks, and I wanted to highlight that there's still opportunities to make incremental change in our symptomatic treatments for epilepsy, especially better tolerability, better impact on comorbidities, and teratogenic risk and all that things. But we also obviously need revolutionary change. We need medications that can alter the trajectory of epilepsy, can make people who are drug resistant, drug sensitive, who can even cure the epilepsy. And I think I want to posit that some of these things that are in development, but genetic and cell-based therapies, may make that big step possible. And that may be in our future soon. So with that, I want to thank everybody for their time, and just want to express my enthusiasm that epilepsy remains an active area of therapeutic development. The last I heard, there were over 100 companies developing treatments for the epilepsies. And so, these are my thoughts about, where we think we should go in the future directions. Interested in questions and discussions, certainly interested in, how you guys think we can leverage emerging tools like AI to better help us in the clinic to choose the right treatment regimen for the patient, but also to identify new targets for therapy and new therapies. So with that, I want to acknowledge again the Epilepsy Study Consortium and the Epilepsy Foundation, which really has allowed me to become involved in this world of drug and device development, and sort of translates my ability to bring hope for a brighter future for my patients who are suffering from their epilepsy.
Thank you, Dr. Friedman. That was really a wonderful overview, very insightful, and really a whirlwind in terms of the future treatments of epilepsy. There are several